Today's symposium is filmed by Community Television of Santa Cruz County. It'll be future cable cast on your local cable station. You'll have to check the time and listings, but it gets repeatedly cable cast for eternity. But I want to make a point about that. Besides the 450 people in this room who are receiving the information today, literally thousands and thousands of people will also get very vital educational information that's good for everybody who's going to hear it. Again, thank you for coming in. I want to now introduce Jon Nadherny Calciano.
Good afternoon, and welcome to our 9th annual Jon E. Nadherny Memorial Calciano Youth Symposium. My name is Joshua Nadherny Calciano, and Jon was my brother. The symposiums were started in his memory. Our family is incredibly gratified to have seen the symposia in memory of our son and brother Jon develop over the years into the widely attended event of today. Jon was 23 years old when he passed, and as difficult as our loss continues to be, the sense of community coming together helping to prevent other similar tragedies from affecting other families is a very healing force. This year is particularly difficult because sadly just a few days ago I received word that my grandmother had passed. She was Jon and mine, our paternal grandmother. She was a wonderful woman and had a deep impact on our lives together. Our appreciation goes out to all those who have helped develop the initial concept and contributed to the funding and planned the details of each annual symposia. We continue to be impressed by the literally thousands of attendees, counselors, educators, parents, and public safety officials such as yourself who have day-to-day contact with youth that have attended the symposia over the years. The post-symposia comments and the number of attendees that return year after year clearly shows that together we are making a real impact in our community. We invite all those interested in helping provide our local youth with a healthy and behavioral environment and the best possible support system to join us in this and in future symposia. Nothing could be a better tribute to my brother Jon. Thank you. And now it is my distinct pleasure to introduce our feature speaker, Dr. Elizabeth McCauley. Dr. McCauley is professor and associate director of child and adolescent psychiatry at the University of Washington and Children's Hospital and Regional Medical Center. Dr. McCauley has been actively involved with national and local efforts to disseminate training in evidence-based treatment strategies to child mental health care providers and is currently actively engaged in working with King County Public Health, Seattle Public Schools, and the Nelsham Foundation to provide training and consultation to schools-based mental health providers. She is currently the president of the American Psychological Association Society for Clinical Child and Adolescent Psychology and is on the Research Grants Committee for the American Foundation for Suicide Prevention. Dr. McCauley.
Well, thank you for having me. It's an honor to speak in this forum and in honor of this occasion. It's also very nice to come to Santa Cruz because it was raining in Seattle when I left and it'll probably be raining in Seattle when I go back, so it's nice to get a little sunshine. I'm going to try to provide, got to get all my technological gear here. I'm going to try to provide today a pretty broad strokes overview of kind of the current thinking, data, etc., as it relates to the related but not totally overlapping problems of youth suicide and deliberate self-harm behavior. So I'm going to be integrating information on both of those themes. So my goal is to do a little bit of definitions just so that we are on the same page, to talk about some recent statistics and trends, to introduce at least what are some of the controversies that may be important to be, we might want to talk some more about in the question and answer session, to talk some about causal models, and finally to talk a little bit about treatment. So I have a pretty ambitious set of goals here, and we'll see how far we go. So in terms of definitions, first of all, let me say that it's always delightful to have the opportunity to talk with other professionals who have made a commitment to working with youth and made a commitment to being interested, available, willing to work with kids who engage in some behaviors that can be scary to all of us. And I feel like I am a person that really loves to work with adolescents, and that isn't true for everybody. It's not a good fit for everybody, but it's really, I think we are in an exciting moment in the work that we're doing with adolescents, and it's an exciting time. So in terms of definitions, when I first trained years and years and years ago, there was this kind of divide. People talked about suicidal behavior and people talked about self-harm behavior, and there was a notion that we had two totally different classes of behavior. And I think now we have a much more sophisticated sense of kind of behaviors that interface with each other, increase risk one for the other, and there's more of a kind of a spiral or connection. So when I talk about deliberate self-harm, I'm going to be talking about, this is the one of the definitions that's been put out by a European group, purposeful self-harm, cutting, jumping, etc. behavior, such as ingestion of substances in excess of therapeutic dose, ingestion of recreational drug with intent to self-harm, ingestion of non-ingestible substances or objects. Then we move to suicidal ideation, which is thoughts of death and dying, wishing to be dead, thoughts of hurting oneself and having a plan, and then suicide attempt and suicide. So there's a whole continuum of behaviors here. And I put that even in emergency departments, the statistics would suggest that when a child or adolescent presents in an emergency department following a suicide attempt, that only about 1/3 of those report that they have a persistent wish to die or even had a wish to die at the moment of the gesture. So again, some definitions, and this is just a kind of a extension of the self-harm definition. But I want to really focus on the issue of the intent may vary, and that's what where I think it gets confusing as we talk about suicidal behavior and self-harming behavior. Because some people engage in these behaviors without any intent to die, others have ambivalent intent, and some people do have an intent to die and move from self-harming, deliberate self-harming behavior to actual suicidal ideation and suicidal behavior. And still others make a distinction between deliberate self-harming behavior and self-harming behavior that occurs during a dissociative state. So this is a complicated area. My point is just to kind of acknowledge that there's many variations on this behavior, and we're going to be trying to talk in general about some of the themes that are consistent across these groups of people, and also ways in which they are distinguished. So self-harm versus suicide. Self-harm is a major risk factor for completed suicide, either by accident or habituation. So as you engage in self-harming behavior, it kind of lowers your threshold to engage in maybe more dangerous or riskier behavior. The higher the frequency of self-harm, the higher the risk for completed suicide. And self-harm is not a suicide prevention strategy. Would really want to underscore that it doesn't kind of relieve tension or kind of get you out of that risk pool. Is my loudness okay, and do I have any feedback? Okay, because I can't quite tell. Okay, thank you. Let me know if I stop talking loud enough. So if we talk about the prevalence, adolescent is a period of increased risk for self-harm behaviors as well as for suicidal thoughts and suicidal behaviors. So suicide attempts, I'm sure I'm not telling you anything you don't know, is a third leading cause of death among adolescents in the United States in the 15 to 25 age range, the fifth leading cause of death among youth in the 5 to 14 age range. And we know that there's multiple attempts for every completed suicide, and it's the number of suicide attempts is a statistic that's really impossible to totally nail down. In terms of self-harm behaviors in community samples, the rates that have been reported most recently are 14 to 39%, 39% being a pretty, I think, alarming number for all of us. In psychiatric inpatient samples, so at a more extreme end of the continuum of youth, you get 40 to 61%, and there's approximately 25,000 emergency department visits yearly for self-harm related events among adolescents. So these are not problems that we can sweep under the carpet or we don't want to take seriously. In terms of recent trends, we have some really, I would say, good news. And that is that there has been, as you may know or you probably have followed in the literature, in the United States there was a really dramatic increase in the rate of suicides as you followed youth through the 1970s and the 1980s. But then since 1990 there's actually been a decline in the rate of youth suicide. But there's been changes in methods, and we'll talk a little bit about that, and also changes in patterns within ethnic groups. In terms of deliberate self-harming behavior, we've got somewhat of a different trend. We've had an increase in prevalence, increases in frequency, and increases and a better articulation of factors associated with these problems or these behaviors. So if we look at the prevalence of adolescent suicide, now I have to change to another I'm not a technological person, so here we go. Let's see if we can do this. This is just to show that for a long time we were really concerned about the issue that most adolescents, that we were having this increased trend in terms of the rate, and now we see this slight decline. It's not a dramatic decline. So the latter two, these bottom two are girls, and these are African American males, and we saw fairly low rates and then a real incline in the early 1990s, and now kind of a leveling off, a decline and a leveling off. And then these are the populations of white males and then all males. So again, in all groups, other than the girls who are pretty level, we're seeing somewhat of a decline if we look to from 1990 to 2000. So that's good news. We also have some changes in trends, and the changes in trends in terms of methods might also speak a little bit to why we have declines in rates of suicide. So in the 1990s, if those of you that were practicing or kind of working in this field, I think you probably remember that there was a tremendous concern about the increase in suicides secondary to access to guns. That kind of paralleled the growing number of guns that were available within households in the United States, and it became became the major way that young people were killing themselves in the United States. But now we've seen a change in that trend, so that the rate of youth, particularly really young youth who are dying because of firearms, has gone down. Whereas suffocation has increased. That's not good news, but we're just seeing some different patterns. Poisoning with these young kids has been always pretty low. And we see a similar kind of change, not quite as dramatic, if we look at the older kids, the older adolescents, where again we see a decline in the use of firearms, a slight increase, certainly not overcoming the rate in terms of risk from firearms, but a slight increase in terms of suffocation and fairly stable in terms of poisoning and other methodologies. So what do these changing trends tell us? I think one of the things that they tell us is, first of all, that our public health efforts can really be effective in changing patterns of behavior. And by that I mean the fact that the American Academy of Pediatrics, the Child Psychiatry Associations, many of the professional associations took a pretty active stance in moving forward to do a better job of educating families about the risks of having a firearm that wasn't locked up, that didn't have a safety lock on it, or that wasn't in a safe situation. That was a pretty dangerous thing to have in the household with an adolescent. And although some of the research work that's tried to look at how effective have been those educational campaigns have been, at least in emergency rooms, hasn't been really impressive. It does seem that many families have taken heed, and that we're hoping or assuming that part of this this decline in the rates of suicide and the change in method has to do with people having less ready access to a firearm. But we also see that you can see some pretty rapid shifts in youth suicidal behavior. That we do see kids developing different patterns. I don't know if it happened in your area, but in Seattle in the last about 2 years there was a couple of kids who died from asphyxiation, and this kind of choking game became very popular, and there was a lot of confusion about, was that an active attempt to self-harm? Was it a social behavior gone awry? Was it a sexual arousal behavior gone awry? People were very confused about what it was, but we did lose 2 young kids in our community by a pattern of behavior that seemed to be kind of moving through groups of kids. And then I think we also need to be aware of differential profiles of risk, motivation, behavior, and intent that differ by kids in terms of their ethnic background. And I just want to show you one, here we go, slide about what we found with what's currently found about youth, Hispanic youth. And that is that, generally speaking, we've thought of Hispanic youth as being at a lower risk for suicide. But by 2020, the Hispanic population in the United States is going to be 17% of the entire population. And although the rates of suicide are lower overall, it's still the 3rd leading cause of death among 10 to 24-year-olds in the Hispanic population. The methods most typically used are firearms, suffocation, and poisoning. But I think that what I mainly want to draw your attention to, or most importantly underscores, this issue of growing risk. That Hispanic youth assessed, surveyed in the 9th to 12th grades, particularly females, report more sadness, more hopelessness, more suicidal ideation and attempts than white or black non-Hispanic youth. So we have a cluster, kind of an up-and-coming large population cluster of youth who have considerable risk. The factors thought to be associated with that are mental health problems, substance use, and probably more important or more unique is the whole issue of acculturational stress, family issues, and low SES. And I think, again, in the Seattle area, we see a big acculturation stress. We don't have the Hispanic population that you have in California, but we have a huge Asian and Pacific island population, and many of those immigrant kids are really they're kind of in the throes of a cultural clash because their families are kind of old school, old world, and they're totally in the public schools, very much Americanized, for better or for worse, and really struggling with what it means to be, where do they fit, and if they break a rule, what are their options? And they get very quickly, we see a lot of those kids getting very quickly suicidal because they don't feel like they have any options, and talking about mental health issues is very difficult in their families. So we have to realize that our groups are going to be very different. Our socio-cultural groups are going to be very different. and there's a lot we need to learn about how best to intervene with those groups. The next two slides, and these are in your handouts. I've done some editing of the slides in your handouts, but I'm not so sure which version is going to come up, so we'll see. You'll see and I'll see at the same time if we all have the same version or I have a slightly updated version on the screen. But I put up the next two slides are two large-scale studies, one done in Australia and one done in the United Kingdom, that look at not so much the issue specifically of suicide, but really look at this issue of deliberate self-harm to try to give you some updated statistics in that front. And both Australia and the United Kingdom, because of the way they have their healthcare services, are better able than we are in the United States to provide these large-based kinds of studies. So in Australia, and I want to, I probably should have put factors from both studies on the same slide, but really what I want you to, as we walk through these slides, draw your attention to is the very marked similarity in the patterns that we're seeing. So these are large-scale studies, 4,000 teens, mean age 15.4, so you've got kids that were all in the United States, probably freshmen or sophomores in high school, if they were in the United States. And they found in the Australian study that 8.4 reported a history of deliberate self-harm within the year. The 6.2 in parentheses is just that the researchers had some very strict criteria. So 8.2% of the kids reported deliberate self-harm behaviors, and 8.4 and 6.2 met their very strict criteria that the researchers required to include in the group. Not surprisingly, we had a much higher rate of females than males, which is a consistent finding. And that you see that cutting is, by and large, the most common deliberate self-harming behavior, followed by medications, followed by illicit drugs, self-battery, and then sniffing or inhalation of a substance. Associated factors, and this again you'll see comes across both studies, thousands of miles apart. Obviously there's some cultural similarities across the populations, but exposure to self-harm in family and friends was the primary risk factor. Smoking, not even smoking very much, was a risk factor, and we know that for adolescents, risky behavior kind of clusters, and so we have that cluster of risky behavior, somewhat risky behavior. Boyfriend-girlfriend problems, part of everyday life for any adolescent or for many adolescents, and yet they're clearly associated with these self-harming behaviors. Amphetamine use, self-prescribing medications, coping by blaming self, and then the last factor they found to be statistically significant, and you realize if you do a study with we all love to do studies with 4,000 people because a lot of things are statistically significant, that if you're living with one parent was associated with a lower rate of deliberate self-harm. And by living with one parent, it didn't mean one parent was better than two, but the other option was to be living without a parent, that you were living in some kind of an alternative situation, either with a step-parent or another family member, but not one of your parents. So then if we kind of flash to the English study, again, slightly larger sample size, but basically the same age. The rates are quite similar, 8.6 versus 6.9 report deliberate self-harm behavior within the year. Almost identical, well, a few more males in England than in Australia, but very similar rates. Again, the methods used very similar. 54.8 of the youth reported that they engaged in multiple acts of self-harm. Only about 12% presented in the emergency room, and about 15% indicated that of those who presented in the emergency room indicated that they had suicidal ideation without deliberate self-harm. Associated factors, again, exposure to self-harm in family and friends, drug use, depression, anxiety, and impulsivity, lower self-esteem, sexual orientation worries, and we can talk about that maybe in the discussion certainly a whole literature on sexual minority youth as a at-risk group in this arena of suicide or self-harming behaviors. History of being bullied, trouble with police, which was only a problem for the girls, and history of sexual abuse, which we know is highly associated with an increased risk for deliberate self-harm. So one of the things that I wanted to talk a little bit about is this issue of, well, I'm going to go back for 1 minute. I don't know how to go back, so I can't go back. There's no going back in this talk. I'm going to talk about why adolescents are so vulnerable, but I think that the version that's up here doesn't have a slide that I added probably yesterday about this issue of bullying, because I think we all hear a lot about who are the kids that are at risk for explosive, violent behavior in the schools. How does bullying play into that? What does it mean for our youth in terms of this issue of being bullied? And a really excellent study was recently done by Madeline Gould at Columbia and some of her colleagues, looking at a large sample of high school students in the New York State area. And what they found in that study was that a substantial proportion of kids, again, we're not talking about huge numbers of kids, but about 10% of kids reported themselves as frequently the victims of bullies. And about an equal number reported themselves as frequently being bullies, engaging in bullying behavior, if you will. And what they found in terms of risk for mental health problems, reported suicidal ideation, and also history of suicide attempts, is that the group of youth, and this won't surprise any of you, but I think it's always good to have our hunches documented carefully in research, is that the group of kids that were most at risk for depression, suicidal attempts, and suicidal ideation were that cluster of kids that were both bullies and victims. So the kids that are kind of caught in that cycle where they're either being victimized at school and so then they bully somebody else in their community or in another setting, or whether they are bullying kids at school and then get victimized in another setting. But the kids that had that kind of were dealing with both ends of the continuum were particularly at increased risk. It's like a 33 to 35 in times the rate of the other kids in terms of having significant depression, suicidal ideation, or suicidal behavior. So those are particularly vulnerable kids that we need to be paying attention to. They found that it was also the girls who bullied, the girls who reported bullying, engaging in bullying behavior, also were at particularly high risk for depression and suicidal ideation and suicide attempts, clearly being uncomfortable with their behavior, but also engaging in that behavior to maintain their place in the hierarchy or whatever is the situation that promotes that kind of behavior. So bullying is a factor that we need to really be mindful of, be asking about when we assess kids. I know some of you work in the schools, and I know there's some excellent school-wide anti-bullying programs that are now available to all of us, so it's something we really have to be mindful of. So now to move on to this issue of why are adolescents so vulnerable, and this is an area where I have I think any of us that work with adolescents, I feel like this is an area of some passion for me, that we really do need to understand what's going on with adolescence and why this is such a vulnerable period of life. And I like to remind parents that when you think your adolescent is not thinking like you or doesn't seem to be a rational person, the data would suggest that your adolescent is not thinking like you and is probably, just like you, not all the time a rational person. So even though adolescence represents one of the healthiest periods of time in terms of severe medical illness, we really see a tremendous increase in mortality and morbidity associated with what we would consider behavioral health problems that have to do with impulse control and emotion regulation. So this is really where we see that increase in accidents, increase in homicides, suicide we've talked about, depression, anorexia, bulimia, alcohol and substance abuse takes off for many kids during this adolescent period, STDs and unwanted pregnancies. So this is not a risk-free period, but it's not a high risk in the traditional medical sense. And so in the last, I would say 7 to 10 years, there's been a really burgeoning of research that has tried to understand what is going on in this transition into and through adolescence. Why are we seeing these behaviors? Why do we see this increased risk, risky kind of behavior, dangerous kind of behavior? What's causing it? What could we do about it? And what's it all about? And one of the things that we've learned, certainly independently of looking at risk behavior, but just in looking at development, we used to think, even a decade ago, I think most people thought that most central nervous system development happened in that period in early childhood. There was a lot of brain development, and then there was a period where you just kind of move forward. And we didn't think there was a lot of growth and development in terms of changes in the brain during the adolescent period. And that, I think, is really we now know that it is the second period of growth and development where there's structural changes, and they're the same kinds of changes that happen in very early childhood, where you get the completion of brain cell genesis, nerve myelination, dendrite pruning in the frontal cortex. All the kinds of things that we think happen with those preschoolers are happening again with adolescents. And that this begins probably at the very early time of puberty. You know, each child is going to develop at their own rate, but this is probably happening as kids are 10, 11, 12, 13, and we know it actually extends, this period of central nervous system development extends through the adolescent and into the early adulthood, young adulthood period. So really into this period exactly that we're talking about of kids who are 10, 11, 12, up to early 20s. These developments lay the foundation for more sophisticated executive function or more sophisticated problem solving. So we think about, if you think about how kids learn how we all learned as we were developing, how we came from being people who were tied to the concrete world and made decisions based on the concrete world to being more flexible thinkers, where we could think about the pros and cons of a situation, maybe the long-term consequences of a situation, that we could learn to do some delay of gratification. Those are the kinds of skills that we think now are the more executive problem-solving skills that come at the later phase of this developmental period. And some of the things that we've learned, and we're still learning, this is ongoing research, much of it is done by a collaborator, I'm proud to say, of mine, named Ron Dahl, who's at the University of Pittsburgh. And what we've really begun to do is document what I think most parents already were suspecting, is that puberty really does change how kids think, that something's really going on in puberty. It isn't just breast development, it isn't just height development, something else is going on that's pretty powerful. So that we now know that there's changes that are associated with puberty, the exposure to pubertal hormones, that is related to changes in behavior. And first of all, I think all suspected this from the animal models, where it's much easier for us, particularly in rats, to really titrate exposure to pubertal hormones and look at behavior changes, because we can kind of add those hormones when we want to add them. We can also there are animal studies where they have been not exposed to the pubertal hormones. And what they found with animals is that as the pubertal hormones came on board, there was this increase in sensation seeking. Now we obviously are much more limited in the kind of research we can do with adolescents, but there is a growing body of laboratory tests, fMRI studies, neuroendocrine studies that really document that what we think what happens for adolescents as they get exposed to pubertal hormones is they really do have, I can't go back, so I don't know how to go back. Anyway, I could walk you through this one. They really do have periods of increased moodiness, not a surprise to any person in this room who's lived with an adolescent. Maybe not a surprise if you remember your own adolescence. So increased moodiness is an issue. The other thing that's an issue is that you do get, I'm going to experiment with, maybe I can go back. Did I go back? Yes. Breakthrough, there you go. Okay, hey, I can be competent too. You know, competence is an important thing. So anyway, mood regulation is something that now there's a growing body of data to suggest is related to exposure to pubertal hormones. Romantic interests is another, again, not a surprise, this isn't rocket science, but to have it really documented that as kids get exposed to pubertal hormones, that really does turn on some little switches in their brains, and all of a sudden they become interested in you know, boyfriends, girlfriends, what have you. I always like to tell a story of a friend of mine who had a son who was a very intellectual, kind of a nerdy, not very social guy at all. And his mom walked by their TV room one day, or their study, and he was all of a sudden watching on TV with intent some advertisement for girls in swimming suits. And she said, "George, what's going on?" And he said, "I don't know, Mom. Suddenly it's interesting." So we think that's hormone. The other thing that we certainly have very sophisticated data on is that as adolescents get exposed to pubertal hormones, there are dramatic, for some kids, more subtle for other kids, but pretty much across the board changes in sleep-wake cycles, which is a very, you know that if you've lived with an adolescent, they go to bed later, they get up later, that would be the natural cycle. I don't know what it's like here, but in Seattle, we still have those high school kids have to be at school at 7:15, which means they have to get up at 5 o'clock because they have to do their hair, and they have to, you know, things have to be kind of set for them. Not good planning, because most of them are staying up quite late at night. And then the last thing is this increase in risk-taking behavior, which we now think that kind of interest in pushing the envelope, doing something that's a little bit beyond the pale, a little bit rule-breaking, a little bit out there, is something that's also probably plugged a little or spurred a little bit by exposure to pubertal hormones. So Rondal and his colleagues are exploring some of these mechanisms, and one of the things that they suggest they're exploring, so I'm just throwing this out as a hypothesis to be tested, that's being tested, is that there's a rise in, as the rise in estrogen availability happens during puberty, that has an impact on the functional integrity of the amygdala and the prefrontal cortex, which are associated with kind of impulse control and planful behavior. So the emotional changes, we have these emotional changes associated with puberty, and then we have cognitive changes, inhibitory control, problem solving, being able to kind of plan into the future and think about, if I get drunk tonight, that could have consequences for me tomorrow. If I blow off my math test, that could have consequences for me tomorrow. Longer term planning, those are more related to increasing age and experience. So we have kind of one thing that's turning these kids on, which is hormones, and the other thing, which is coming a little bit later, which is experience that makes them good problem solvers. So one of the hypotheses is the reason that we have such a adolescents are at such risk for emotional and behavior problems is this lack of synchrony between kind of being turned on emotionally and when really solid problem-solving skills kick in. So one of the things that you have is kids who are very highly emotional, but they really are they're not yet able to make rational decisions in the face of intense emotions. So when you're at that party and everybody's saying, do this, you want to be cool, this is the time, it's very hard to make a rational decision or a planful decision. The other thing that characterizes these adolescents is that they're they're prone, cognitively prone at this point, because they really haven't matured to be really flexible thinkers, to biased interpretations of data. And that means they're very self-absorbed, very self-conscious. One of the things that we know about adolescents is this incredible kind of focus on self and attention to self, which is typically critical. So those of you that work with adolescent girls, you know, they can go through kind of every feature, especially body weight, but other features, and say, this isn't right, this is too big, this is too little, this is, you know, they can be very, very critical. And they don't really have good inhibitory control, and they tend to use emotion coping, focused coping, which means to not focus on how to solve the problem, but to focus on the emotional arousal associated with the problem. So what Randolph's, like the phrase that he's coined is that it's starting the engine with an unskilled driver. So the engine's going full bore, but the driver's really not ready to be in the driver's seat. Okay, now I got to try to go back again. Just as we're finishing up, I'm going to get this down perfectly. So now I want to move, I just want to give a sense of as we deal with adolescents, we're going to be dealing with these risky behaviors because that is the nature of adolescence. It's not because they're some intrinsic problem or difficulty or issue with these kids. They're in a vulnerable period of time. The next thing I wanted to do is talk a little bit about what are some of the controversies. And again, I don't know if this is an issue that you guys have run into in your community, but I think it's an issue that comes up a lot in school communities or other communities where people are nervous about whether if you ask kids about suicide, are you going to perpetuate or trigger or inspire them to engage in suicidal behavior? I think that it's been a big issue. It's one of the reasons that we have, I would say, compared to our research on treatment of anxiety disorders and our research on treatment of depression or ADHD or other problems that kids struggle with, why the research on management of suicide is a little bit behind. Because people are very hesitant to IRBs, institutional review boards at universities and hospitals, school district institutional review boards are hesitant for people to ask kids about suicide. So you can't even engage in the initial discussion to begin to get your initial data to move forward. So this has been I think at least for those of us trying to look in a more research context, a big difficulty that people don't want you to talk about suicide. And I think it's worrisome to families. If you're going to ask about suicide, what does that mean? Are you going to trigger something? So Madeline Gould, who is an epidemiologist at Columbia and has done a lot of really terrific work on adolescent suicide, I'm sure that you've read some of her work, asked the question really systematically in a research context, does asking about suicide ideation or suicide behavior create distress or increase suicidal ideation among high school students? Generally, are among high school students already reporting depressive symptoms. So she was really trying to look at, okay, maybe if we ask kids in the general population, there wouldn't be an effect, but if we ask kids at risk, there's going to be an effect, and we need to know what's going on. Again, looked at a large sample of kids in the New York State. They looked at classes of kids who were randomized to an experimental versus a control group, and that just meant who received suicide questions, etc., and then followed up with these kids afterwards. And exposure, being asked about suicide, suicidal ideation, suicidal behavior, was not associated with differences in distress, depression, or suicidal ideation, not for the high-risk group and not for the low-risk group. So I think it's an important study for those of us doing this kind of work, because it really backs up that we can get this information, that this isn't a dangerous territory to be entering in, that there isn't an iatrogenic effect of just asking about suicide. I think the other controversy, and I can't imagine that you aren't totally aware of this one because it's everywhere, is this whole controversy about medications as a trigger for suicide and suicidal ideation and behavior among adolescents. And just to give you a little bit of background, you know, when the SSRIs came on board, I think all of us had more hesitancies when we could treat depression with the tricyclics, because the tricyclics had a lot of cardiac side effects and some difficulties in terms of kids taking them. And so I think they were used more cautiously, more sparingly. And then the SSRIs came on board, and we got a really tremendous increase in the number of kids, 3 to 8-fold increase in the use of antidepressants among children and adolescents from about 1990 to about 2000, and this is some research documented by the investigators cited. And the data, so we got a huge increase. The data on the efficacy of antidepressant medications, at least with depressed adolescents, is not as robust as we would like it to be. I think it's still a cautionary tale. But fluoxetine does seem to be the medication that has some proven efficacy. But still, even with that, up to 40% of youth are non-responders. So that's a good chunk of kids who would be identified as having some significant depression. We know depression is very strongly related to both suicide and self-harming behavior. And yet, with medications, there's at least 40% that are non-responders. There's also some other complicating issues to throw in there about this issue of medications and treating kids who are at risk for suicide and self-harming behavior. And that is the issues of resistance and adherence to taking medications that many people have written about and has been well documented in adolescent populations. So Gray did a large-scale study and found that 69% of the youth who were prescribed an SSRI stopped taking meds by the end of 4 weeks. 58 to 61% reported a negative bias towards meds. That doesn't mean they have a stronger bias towards psychotherapy, let me add, but there is a negative bias. Many kids are reluctant, and I think here's the kind of reasons that they give, and I have certainly heard this directly, and so my guess is you've heard this directly, that the medicines might change my personality, control my thoughts, not let me be myself. The other thing that I've heard quite commonly, wasn't cited in this study, but so just anecdotally in my own clinical experience, is that kids feel like they somehow should do this on their own. They should be able to kind of overcome their feelings, their urges, their thoughts on their own. So it's a kind of the good old Yankee ingenuity, pull yourself up by the bootstraps, not rely on a medication kind of approach. And then there's a lot of issues about the belief in the efficacy of medications and stigma about use of medications. So medications are not a simple topic when it comes to their use with adolescents on many, many fronts. And I think that most of us now are really doing a pretty careful assessment of what do you think is causing you to feel this way, what do you think would be an effective way to intervene, and kind of trying to develop a partnership around the use of medications if we think it's indicated. This is a study that we actually did, Laura Richardson and I did at the University of Washington, where we looked at kids who were prescribed. We were looking at whether kids were getting the kind of follow-up they needed, which, you know, by the new guidelines, you need to be followed up pretty carefully if you're prescribed a medication. But we found that most kids were not getting followed up according to the guidelines. But what I wanted to show you why I wanted to include this is it's just a graphic representation of what happens for many adolescents when they're prescribed medications. And I think it's particularly true, and I'll be really open to discussion about this in the question and answer. I think it's particularly true when kids are prescribed medication without the context of a larger treatment plan or a more organized treatment plan. So many of a large percentage of these kids stop taking their medications. By 6 months, you have almost everybody stopping taking their medications. And what happens for the kids in terms of stopping, why do they stop? They stop because they begin to feel better. They stop because they don't want to be bothered with the medications. They stop because they went to somebody's house for a week or on vacation for a week and they forgot to take the medications, and then they were off the medications, and then they weren't very motivated to start again. Or they had taken the medication so erratically, if you will, that their care providers, in agreement with them, decided it wasn't a good treatment because they were taking them when they felt bad, but not taking them when they were having a good day, and so the medication effect was really getting compromised. So my bottom line point here is that I'm going to talk a minute about the relationship between medication and suicide, but medication is complicated. Psychotherapy is also complicated. I don't mean to suggest it isn't, but these are not just kind of easy issues to sort out. So as you know, given the fact that there was an increased concern about the SSRIs triggering suicidal ideation among adolescents, there's been this black box warning that it suggests that, see, I keep thinking that I can use this as a pointer. I have magical thinking going on. So anyway, they have monitoring providers to monitor weekly for 4 weeks, monitor for approximately 3 months, monitor for agitation, anxiety, insomnia, irritability, hostility, impulsivity, restlessness, mania, as well as suicidal ideation. And I think that the difficulty with the monitoring, and again, I'll defer to my colleagues who prescribe, is it can be very difficult to get the adolescents back in for the monitoring, even in the best, if the prescribing physician has the best of intentions. So if we look at the data about what is really the relationship between use of antidepressant medications, there's been a meta-analysis that's looked at 23 studies with 9 different psychotropic medications, predominantly SSRIs. And there was a 2-to-1 increase in the risk of documented suicide attempts for kids on the active medication versus placebo. But there have been no documented, within these studies, no documented completed suicides. I know there's anecdotal information and you may have your own personal experience, but within the context of these studies where they've tried to draw together as many, really a large-scale look, they haven't found any documented evidence. So this is the meta-analysis. No completed suicides. And why do they think that's true? They think that's true because there's increased monitoring in these studies, so these kids are really being followed carefully. They found no evidence for medication associated with the emergence of suicidality, and I think this is another important issue, and I don't think we have the answers, or this is a closed book. But the reality is that if you're going to deal with high-risk adolescents, depressed, impulsive, aggressive adolescents, you're going to be dealing with suicidality in a large number of those kids. It's part and parcel with the problem that you're dealing with. So it's a little bit simplistic to think that medication causes a set of symptoms that were probably present to some degree before the medication was started. We just need to be kind of aware of that the medications may be activating youth, so we see more suicidal ideation, but are the medications causing the initiation of a thought pattern that was never present before? I think that's where the data is a little bit dubious. They found no evidence for the medication associated with worsening of suicidal symptomatology, but they did find that the medications are associated with activation. And we know from years and years and years of research in the with adults that as people begin to get better and get activated, that's when you have that increase in suicide risk. So there's a couple of things we have to keep in mind, and I'm just trying to give you the things to keep in mind, not say there's an absolute answer here. So if you look at the TAD study, which has the largest treatment for adolescent depression study, the largest study done in the United States, and I would say probably to date the largest study done on the treatment of depression, including Australia and Britain, that 6 of the 7 kids who made an attempt in that study, and it was a large-scale study, so there are a couple hundred kids, 6 of the 7 already had a clear suicide flag at entry into the study. So this is a behavior that's present, a behavior that we're all kind of monitoring, worrying about, attending to appropriately. We should be. But it's not clear that medication is the only, is solely responsible. And they also found, and we're going to talk a little bit more about this later when we talk about treatment, that for them, in the TAD study, the combination of pharmacotherapy, which was Prozac, and CBT was best for the reduction of suicidal ideation. So they walk away from that suggesting that a combined is the way you definitely want to go for a kid with suicidal ideation. You wouldn't want to go with just medication, and you probably wouldn't want to go with just CBT. So if we get into this issue of medication as a trigger, there have been large-scale studies that looked at the pattern as we had access to antidepressants, pretty safe and easy to use antidepressants, the SSRIs with adolescents. There have been a series of studies that have looked at geographic areas and looked at the rate of prescribing of antidepressant medications and the suicide rate and found some association between higher rates of prescribing antidepressant medications and lower suicide rates. So people, these are these large epidemiological studies where they're looking at not individuals but rates of behaviors. But these are very difficult studies. It would be difficult to complete a study to totally resolve this issue because of the need for a large sample. And Greg Simon, a colleague of mine up at the University of Washington, has done a lot of work in this area, and he suggests that we would need a study that included 6,000 youth, and that would be a very challenging treatment study to get it off the ground and pay for and execute. It's a huge number. If a treatment study has a couple hundred kids, people would consider themselves very lucky. So this would be a huge study. And then I think we need to pay attention to the fact that emergent suicidality is a factor in any treatment of depression, or the kind of related adolescent problems. And Bridge, who was working with David Brandt at Pittsburgh, looked at the same pattern of emerging or triggering or increased suicidality in kids who were only getting psychotherapy. And they found that emerging suicidality in 11 of 88 of their kids, so 12.5% of the kids who had not reported current suicidality at the onset as they entered the treatment arm, reported increasing suicidal ideation as they moved through the treatment process. And self-reported suicidal thoughts at intake were a significant predictor. So what does this say? It says that, again, that as we deal with youth who are at risk, we're going to be dealing with suicide and self-harming behavior. And I think we have to kind of figure out how to come to grips with that and be comfortable with that and work on more effective interventions. But I think that this also really underscores the fact that there are some ways to begin to flag and track kids. They used a Beck depression scale that had a suicide item on it, and that was a good predictor of who to follow, who to really follow carefully. And I think for most of us, I'm going to come to this issue of assessment, that it's very important to use these self-reports on a regular basis to help us kind of figure out where we are and how we're doing with the kids that we're working with. So I'm just going to summarize with some recommendations, again, by my colleague Greg Simon, who's written these up in the New England Journal of Medicine just at the end of last year. And he suggests that the efficacy for antidepressant medications is really only established for kids with current major depressive disorder. So his first word of advice is that we should be using these medications only with kids who have had a fairly careful diagnostic workup at where we can say they really meet criteria for a significant depressive disorder. And I think that speaks to how easy it is for a kid to access a comprehensive workup. A lot of these medications are prescribed by people in primary care. And how can we better support our colleagues in primary care to identify the kids in need of intensive treatment. He also suggests that fluoxetine or Prozac, since it's the only proven medication, And approved medication should be the first choice. Now, again, I think we can talk about this in the discussion where what would be the indicators to look to a different medication, but he's just giving these as general guidelines. And then obviously that patients and families need to be clearly warned that suicidal ideation might increase and that aggressive behavior and agitation are also signs of an increased risk, because we know, and we'll talk about this a little bit later, the very strong association between kind of impulsive aggressivity and suicide risk. So the combination of depression and then increased impulsivity and aggressiveness is a very potent and dangerous combination. And then this issue of regular follow-up with active outreach. And again, I'm hoping that we can spend some time as we talk about intervention strategies, because I think that is something that is critically important as we work with suicidal youth, that they aren't going to necessarily fit in a neatly prescribed scheduled week. You have to be pretty available, you have to be pretty dogged about follow-up and contact. And then just some editorial comments about factors that can increase in compliance with treatment. We found that monitoring and targeting specific behaviors and having kind of an experimental approach. So if you kind of are very clear from the get-go, if we're going to try this medication, we're focusing on your sleep, we're going to keep track of whether your sleep is better, and that this is going to be a trial period or an experimentation. If you don't like it, we can move on. Okay. Then I think the final issue, and there's no data on this. I have heard a number of people mention this, so I tried to find data. There's no data. It's just way too soon. That there's really been, since the FDA made its recommendations and its caution about the use of antidepressants with adolescents, there's been a significant decline in the use of antidepressant medications with adolescents, about a 25% decline. That has been documented. There hasn't really been much, the documentation would suggest there hasn't been much change in the follow-up, that it's still difficult to follow those strict guidelines in terms of how often people are seeing kids. But there's now some concern that people are talking about, and this is, I guess, just a tickler because there really is no data on this, that we may begin to be seeing an increase in suicide rates that's complementary or following this decline in the use of antidepressant medication. So it's something to pay attention to over the next, I would say, 3 years to see if we can there is documentation of that. And another controversy, I'm switching mindsets here, another controversy I want to kind of lay out for you all to be thinking about, and again, maybe we can discuss more in the interaction, is this whole use of the influence of the internet. I don't know what it's like for kids in this area, but the kids that we deal with in Seattle, MySpace is their space, and they are frequently engaged in getting on the internet. This study that I'm going to just quickly summarize for you suggested that 80% of 12 to 17-year-olds are using the internet regularly, half daily, primarily for social reasons, and some people have suggested it is a particularly good social outlet, avenue for kids who are socially isolated, kids that are shy, kids that are anxious. But this study tried to look at what was happening for kids in terms of spreading deliberate self-harm behavior by going to these websites. Is there romanticizing of these behaviors going on? Is there kind of a contagion effect about deliberate self-harming behaviors that's happening because the kids are connecting with the internet? So they looked at the prevalence and nature of self-injury on messages on message boards. They looked at 2,942. It seems like a huge amount. That was 10 boards over 2 months, so it's only a drop in the bucket of what's out there in terms of messages. And what they found, I think, is quite interesting, and again, something that we as care providers for these kids need to be aware of. There's a whole other world out there that we're not really impacting. So what they found is that mostly the most common thing where kids were communicating about deliberate self-harm, most commonly they were getting, it was informal support that they were getting from one another, and they were giving to one another. So the kind of messages were just relax, take a breath, apologizing behavior, behavior that kind of confessing how badly they feel about the behavior. 19.2 of the messages were about conflicts with others, depression, schoolwork kind of triggers. 9.1 was about issues around concealment. And some of those messages in the article were pretty asking for very frank information about how you can conceal your the cuts on your arms, that kind of thing. 8.9 about how addictive the behavior was, 7.1 about help seeking, and the researchers commented that it was mainly, the comments were mainly very positive about help seeking, so I think we can feel good about that. And then 6.2 were really about techniques, like how to cut without having it bleed so much. I mean, really detailed on the things that we wouldn't consider to be, that we would worry about. The conclusions that they came to is the internet is providing a powerful vehicle to bring deliberate self-harming youth together, that it has pros and cons, like as if everything else, that mostly the kids engage in typical exchanges, providing support, sharing anecdotes with each other, but that there is exposure to a subculture that normalizes, encourages self-harm behavior. So there is this potential for a contagion effect. So again, as we deal with kids, we need to be checking out who are they communicating with, how are they communicating with them, and is this a kind of silent source of support and reinforcement that maybe if we're dealing with their friends in their everyday life, we're not really touching if we're not talking about these issues. So now I'm going to move on to this issue of kind of causes and vulnerabilities, and I'm not sure if I missed a slide there or if I added one and you guys just, and I don't have it in this presentation. Okay. So vulnerabilities, and these are going to be things that I think we can go through pretty quickly because these are things that, again, I think you're aware of in the work that you do. That there's vulnerabilities to self-harm include depression, anxiety, impulsivity, low self-esteem. Some people say perfectionism that hasn't been 100% supported in the literature. Confused sense of self, sexual orientation is an issue that's come up, and blaming oneself, taking more responsibility. Awareness of self-harm by peers and other family members, I think, is a big issue. We've certainly seen, again, in the Seattle area, and I don't know why Seattle would be unique in this way, groups, clusters of kids in middle schools, clusters of kids in high schools that are sharing self-harm strategies, techniques, information, where there's a pretty strong focus on being part of the in-group to be part of engage in that behavior. Difficult vulnerabilities, family communication issues, criticality in parents, violent and dysfunctional families, use of cigarettes, alcohol and drugs, and criminal history. So it's kind of a whole wide and not very discriminatory range. But if you actually look what kids are saying, these kind of categories come up in terms of why do you engage in this self-harming behavior, deliberate self-harming behavior. Affect modulation, decrease anger and fear, big one. Stop that empty feeling. Punish myself, influence others, express anger towards others this way. Magical control comes up a lot. Prevent one from hurting others, so this is going to somehow control my negative influences, stop me from engaging in negative behavior. And self-stimulation. And I'm going to just go on to these questionnaires. So this is a questionnaire that really looks systematically at why do adolescents engage in self-harm, and it looked at the difference between self-cutters, thinking of those as more deliberate self-harm, and self-poisoners, thinking of those as kids who might be a little bit further along towards suicide on the suicide continuum. And they found that they were basically different on only a few of these points in terms of what they listed. And one had to do with this issue of intent to die or desire to die, much higher among the self-poisoners. And then this issue is you're questioning if someone loves you, again, much higher among the self-poisoners. This is a similar, just a spontaneous remarks. The others were responses to a questionnaire that was given to the kids, and this is what they gave as their spontaneous reasons. And the ways that the two groups differ was the higher number of the self-poisoners were interested in escape, much higher number of the self-cutters were angry at themselves, and I think is as consistent with what I've said and what they were hypothesized, that you had much more intent to die among the kids that were poisoning than the self-cutters. So let's talk a little bit about causal models. It's difficult to time a talk. When I started out, I thought I wouldn't have enough to say. Now I can see we're going to be rushing through some of these slides. So I think it is important to think about what are some of these causal models. So these are first going to talk about suicide. We'll talk a little bit then about self-harm. So in terms of suicide, there's really been pretty sophisticated research, but still in process, still need more work. In terms of the biological models. So heritability has been the focus of a number of studies. And the offspring of parents, if you look at the offspring of parents with mood disorders, we know that those kids are at increased risk for behavioral problems and at increased risk specifically for mood disorders. But if you look among that population of kids, those who have a family history of suicidal behavior, so a parent has made a suicide attempt, those are the kids who are particularly at increased risk for suicide. So people are hypothesizing, what's that all about? What is that related to? And one of the things that people focus on is this role of impulsive aggression, which is highly heritable. And is that kind of the key variable? Is that really the factor that we're seeing? And then there's some other kind of emerging studies that are looking at levels of serotonin, the 5-HIAA metabolite in persons with suicidal behavior and impulsive aggressive behavior, where we find lower levels, and also some MRI studies which are finding differences, alterations in the number and function of serotonin receptors in the prefrontal cortex, which again, as we've said earlier, is related to emotion regulation and behavior inhibition. So it may be that what you're getting is, for some of these kids, and it always has to be said in the context of suicide, is we have these risk factors, and yet there's a subset of kids who don't demonstrate any risk factors, who move on to engage in suicidal behavior, ideation, and unfortunately some complete suicide. So we're talking about the risk factors that might characterize a group of kids, but there's always going to be those kids that we don't really know what's going on for them. I'm going to move on. This is a model that David Brent has, but it's impossible to read, so I'm going to move on. Again, if we talk about this issue of serotonin and deliberate self-harming behavior, there's some initial findings of evidence that self-harming behavior is associated with lower levels of presynaptic serotonin release. So again, we may be seeing some altered function in the serotonin system that increases an individual's risk for self-harm behavior across a broad continuum. There's also the issue of the endogenous opioid system hypothesis, and these are hypotheses with just beginning research to bolster them or support them. And there's two hypotheses out there. One is that the addiction hypothesis, which is that the EOS system, which is repetitively activated by deliberate self-harm, produces an elevation in mood. And again, I think we've probably all talked to kids who say that they feel better after they've engaged in some of these self-harming behaviors, that they get an elevation in mood. And then the pain hypothesis is that individuals with deliberate self-harm have an altered EOS system, either congenitally or secondary to repeated exposure to self-harm, leading to neurochemical alterations which really reduce their pain response. So they're not experiencing pain at the levels that one would anticipate that they would experience given the behaviors they're engaging in. Again, I think these are areas, provocative areas for additional research, but things that we need to be aware of as we're working with the kids that we are serving. In terms of behavioral models, these are a little bit more straightforward, but again, data is needed to support them. And these are social learning hypotheses, is that you have learned behavior and modeling, and we certainly see that in the kids who pick up these behaviors on inpatient units. I've worked for many a moon on an inpatient unit, and I have to say, I think the kids do teach each other these things. We certainly see it in these little clusters in schools. Behaviors are maintained, and this is probably the more important thing for all of us as we look at intervention, by reinforcement contingencies. So negative reinforcement, you avoid a more adversive consequence. So you're feeling really intensely upset, really intensely alone, you engage in some cutting behavior, you feel better, you maybe have a little bit of a rush, and so you are released from that really negative, more adversive consequence or set of feelings. And then positive reinforcement means that you get attention, inclusion, sense of relief. We've talked a little bit about that with negative, and then tension reduction. And then I think the third predominant model out there is the biosocial model, our theory, and this is really grows out of Marshall Linehan, one of my colleagues in the psychology department at the University of Washington, where you have an emotionally vulnerable individual, an invalidating environment, and that equals pervasive emotional, behavioral, interpersonal, cognitive, and self-dysregulation. And we'll talk a little bit more about that. So emotional vulnerability in Marsh's model suggests you have high sensitivity, you have immediate and high sensitivity person, and Marsh's model would really suggest that this is just biologically, innately, temperamentally who you are, the way you are, that you have a really low threshold for responding. So if there was a really loud bang in this room, somebody dropped something, some of us would just sit there, some of us would jump to the ceiling, and some of us would maybe jump a tiny little bit. And that's just kind of our arousal level, our response level. It's who we are. Some of that can certainly be shaped by experience, but she would say that you have people who are emotionally vulnerable have a high sensitivity, immediate reactions, and a low threshold for having an emotional reaction. That they're high reactors, extreme reactions, and high arousal dysregulates cognitive processing. So if there was a really loud bang and I'm really highly reacting and emotionally aroused, it's going to be harder for me to think, oh, that's just that poor person dropped a tray, it's no big deal, because I'm rushing ahead to some other more disastrous kind of circumstance in my mind. And then slow to return to baseline. These are people who, when they react, they stay dysregulated. They stay in a high emotional state of dysregulation or poor regulation for a longer period of time. So that makes you even more sensitive to your next stimulus because you're kind of waiting for that next negative interaction or stimulus. And then the other piece of Marsh's model that's critical is this issue of invalidating environment. And an invalidating environment doesn't mean just that you were poorly parented. It really means that the kinds of things that we all struggle with as parents, where we have a kid who doesn't have the temperament that's easy for us to interact with, doesn't have the natural style that kind of draws out the best of us. And I can really relate to this I had a kid who was a really sporto guy, and I never did figure out what offsides was, but I did go to more soccer games than anybody. It felt like anybody on the face of the earth. And I would have done better with a little nerdy bookworm kind of kid, but that isn't what I got. And I think we all have that experience in our lives where we have to kind of adjust to who our kids are, and that can be easier in a family with a lot of resources or a few stressors. Difficult in a family who's also struggling with multiple stressors. So you have a poorness of fit. Child's expression of private experiences are not validated but are dismissed. And again, I think we've probably, many of us, done this in our weaker parenting moments and certainly heard people do that, where a kid says, here's how I feel, and the parent immediately says, we can't feel that way. In part because it's hard for the parent to hear what the child is saying. It's hard for them to hear that a child may be sad or distressed or upset. So, and in an attempt to be comforting, they say, you don't really feel that way, as opposed to acknowledging and validating, you do feel that way, let's figure out what we're going to do about it. So then the next phrase or next step in Marsh's model would be the child searches the social environment for cues on how to act, think, feel, learn, and feel, and learns to distrust their own cues. So if I say I'm hungry, and repeatedly people say, we can't be hungry, you can't be hungry, you can't be hungry, pretty soon I'm going to be looking around to figure out, how am I going to figure out when I'm supposed to eat, or when I can it's okay to have that feeling. And I'm not going to trust my own cues. And then the child ups the volume, and we know this with aggressive kids too, this up the volume kind of concept. So to convince the invalidating environment that what they're feeling is real, they up the volume. They express it more, they complain more, they get louder about it, and then there's more tension. So the domains of dysregulation include emotional dysregulation, interpersonal dysregulation, which gets us into moving into that realm of more of the borderline personality disorder with all the self-harm behavior that Marsha Linehan's work is really focused on, chaotic relationships, fears of abandonment, self-dysregulation with identity disturbances, difficulties maintaining interpersonal relationships, sense of emptiness, parasuicidal behavior, and cognitive dysregulations. So I'm going to kind of move forward and talk a little bit about treatment approaches and skip prevention for the moment. So a word about assessment, and I have included on the slides, and I can get them, they are not on the slides that you all got, but I have included some information on assessment tools, and I can get them out, have them, get them to you after the talk. But I think that one of the things that is really critical is beginning this whole notion of monitoring behavior. So it's important to do some assessment before you make your treatment plan, assessing changes in key symptoms as you move forward in your treatment, which is going to inform what you're doing, and then assessment of how things are going from the youth and the family's perspective. And the importance of doing a good assessment or doing a case conceptualization in this area, as in most areas of psychotherapy, is that's really going to help you figure out where you're going to go in terms of your treatment and your intervention. And if you look at what's out there for the treatment of suicidal and self-harming behavior, we really don't have an evidence-based approach that we can say this is what we should all be doing and this is how we should all do it. But we do have a series, and that's unfortunate because I think we're still struggling in this area, but we do have a series of promising interventions. But those promising interventions aren't one size fits all. So you really want to be evaluating the nature, the extent, the purpose of the behavior that the child is exhibiting and the context in which the behavior is presenting itself. So if it's presenting itself in the context of a child who has substance abuse problems and multiple other problems, your approach would be different than if it presents itself in the context of a transient or experimental kind of phase, or maybe an occasional coping strategy. If you think about kids who engage in occasional deliberate self-harming behavior, then you're really going to be thinking of a cognitive behavioral therapy approach and probably some motivational interviewing approaches or motivational strategy approaches for partnering with the kid. As the behavior gets a little bit more persistent, a little bit more severe, as a standard coping strategy, you're probably going to be thinking perhaps a cognitive behavioral therapy or some of those intervention techniques, and then moving a little bit more to some of the techniques that are part of the dialectical behavioral therapy technique, particularly even if you don't have the time, the energy, the resource to become fully trained as a dialectical behavioral therapy person because it's a significant commitment. There's a whole bunch of mood management, mood regulation, mindfulness, a whole series of skills that Marcia has developed that are very useful in dealing with these impulsive kids. And there's a brand new book out on dealing with a suicidal adolescent from Marcia's group, which is on the reading list that you got, which I would highly recommend you checking out. And then if you have a kid where your assessment suggests that you really have a lot of impulsive, aggressive behaviors and the kid is in a very complex psychosocial environment, then you might be wanting to look at something very intense, but something more like a multisystemic therapy, because as soon as you get a kid who's got a lot of aggressive and a lot of issues around noncompliance, legal behaviors, more antisocial behaviors, you have to, in all cases it's important to get the families involved, but you really have to get the families involved to be able to help the child make a change, because typically they're in a convoluted environment that is not going to allow for change unless the environment is willing to work on change as well. Okay, I'm going to go on for that. Whoops. Sorry, So just as a reminder about the TAD study, and the TAD study was this treatment for adolescent depression, and it is probably the foremost study which has looked at the use of CBT, specifically cognitive behavioral therapy, specifically as a therapy that's going to have influence on or be effective in reducing suicidal ideation. And they found that it was effective, the combination of medication and cognitive behavioral therapy was most effective in reducing suicidal ideation in their sample. Now I think I'm going to try to go in the other direction and so I just want to talk a little bit about the key issues that, this is really tricky. Okay. There we go. The key issues that are kind of unify are consistent across the various promising interventions for kids in dealing with both suicide and self-harming behavior. And those common features, I think, are important to keep kind of at the forefront of the work that you do. One is that they focus on the suicidal and or the deliberate self-harming behavior directly. They are taking those as the presenting problem that in the moment deserves the most attention, and a plan is made specifically to begin to focus on those and change those behaviors. So they're not saying, okay, this kid is presenting with suicidal ideation and presenting with some deliberate self-harm, but we're going to kind of go over here and deal with that early history of trauma. All of these would suggest that these behaviors need to be stabilized, probably with a combination of introducing skills and behavior management techniques before you can really get to these other behaviors, which may be contributing for sure, but that you're going to focus directly on the self-harming behavior. I think all of the effective interventions focus on that. They also have a fair amount of structure in the amount of contact you have with the kid and the amount of monitoring that you do with the kid and the family. And I think that that's one of the reasons that the DBT approaches have been so effective with the deliberate self-harming behavior of the adult population, is the amount of structure and the monitoring of contact that you have with the therapist around the deliberate self-harming behaviors. And I'm going to talk a little bit more about some of those strategies. I don't know how familiar you all are with DBT. Is that something that people here use a lot of? Any DBTers in the audience? A few people. So basically what it says, and I think you would have the same approach if you were dealing in a cognitive behavior manner, if you have a kid who's engaging in worrisome suicidal or deliberate self-harming behavior, you're going to every session be checking in on that behavior, every session be working on distress management, distress tolerance kinds of skills so that the child and alternative problem-solving kinds of skills so that the child is developing strategies to problem solve other than engaging in self-harming behavior. So that's going to be at the forefront of all of your sessions. And you're monitoring that and monitoring that and problem solving that and problem solving that. And it's only when you feel like those behaviors are really stabilized and in control do you go to some of these broader issues. And I think it's a different way of doing therapy than many of us have thought about in the past. And then they have the flexibility, the effective therapies all have the flexibility to include outreach. And by that I mean when people say, you know, when I'm working in our emergency department and I'm assessing a suicidal adolescent, and the plan is for that child to go home, you know, the plan that we make with that parent and with myself is monitoring, which involves more flexibility in my schedule and in the family schedule than we think about for other behavior problems. I'm not going to say I'll see you next Thursday, usual time, usual place. I'm going to have some check-ins in the interim. I'm going to be talking about with the family about how they're going to monitor the kid's behavior, what they're going to do to kind of keep on top of that behavior. So we've said that there's no thoroughly proven intervention, and the fact that you're going to choose your intervention in part based on the severity of the kid that you're working with. And just to give you some kind of broad overstrokes or overviews of these behaviors, so CBT incorporates behavior, cognition, affect, and social factors, utilizes enactive treatment structures, which are same as kind of the motivational structures or systems that we think are so effective with adolescents, and that just means that you really enter the relationship with the core belief that this person has within them the skills, not necessarily the skills, excuse me, but the ability, the willingness to change and to improve their situations. So you're not doing to them, you're really working with them to mobilize their own skills, their own strengths, their own to empower them to really move forward on their own behalf. It's performance-based procedures, so again, you're doing that monitoring of the things that you're worried about, checking back, setting up trial and error things, so kids try certain things maybe to resist that urge to self-harm. It's not going to work 100%. That's okay. You come back and look where were the pitfalls, what got in the way, why wasn't it successful, was it a little bit successful, so all this kind of partnership. That you have structured sessions, and structured sessions we feel are very critical. That's true for a DBT approach, it's true for a CBT approach, and it's also true for an MST approach, all these initials. Always you are outlining what is going to be your core focus. So you're not you really get off the dime, which is so common with adolescents, of being caught by the crisis of the moment, or the fight of the day, or the thing that's in the moment. You can give attention to the thing that's upsetting the youth, but you can say, okay, let's put that on our agenda. We got a lot of things we need to cover. Remember, we're going to check back on those things you were going to try to do to keep yourself safe, so we got to put that on our agenda, and we got to walk through and touch base on all these things, and we're not going to be drawn away and discover that all our time is up and we are just dealing with this crisis. We've got to keep moving forward. And I say to kids frequently, look, it's my job to keep us moving forward here. So I know you want to talk just about this. I want to hear all about it. It's really important to you. But can we also leave some time to keep moving forward on our agenda to keep you safe, our agenda to keep developing the skills that you need to overcome the urges to harm yourself. So I think so these are just some of the ways that you look at thought records. We kind of did that. I'm going to put in a plug, a blatant plug. Because there aren't effective treatments yet for suicidal behavior, and are really that effective treatments for adolescent depression, we at the University of Washington and Children's Hospital are looking at a behavioral activation approach. And I hope that in a year's time or a year and a half, we'll get some material out to you to say that this is an effective approach. And it really just looks at getting kids moving again in their environments so that they have a rewarding environment and are gainfully engaged. because we find that so much of what happens for adolescents is they develop these really effective, potent avoidance patterns. So they get stressed out, and then they stop dealing with their friends, and they stop going to school, and they stop talking to their parents, and they get themselves pretty walled into this avoidance. And so our goal is to really focus on getting them activated again and helping them understand that what's happened for them is just a loss of enough reinforcement, enough positive events and activities in their home situation or their life situation. So again, here are the critical elements. If you think about a dialectical behavioral therapy approach, a very complicated and sophisticated intervention. If you're going to want to use it as an expert working with adults with, say, borderline personality disorder, but it has some very key elements, some very important elements that are very useful, and Marcia's worked very closely with us as well as other colleagues around the country to really make these user-friendly, accessible to adolescents who are engaging in self-harming behavior. And that would really be many of the attitudes about DBT that are very useful in working with adolescents. One of the first things that you do if you're a DBT therapist is you really go through a process, a commitment process, which is you basically say to the adolescent, this might not be the right therapy for you. It's going to be really hard work. You really need to go away and think for a couple of weeks about whether you want to do this. Those adolescents are clamoring at your door. I mean, that challenge is a very effective way to get them to say, I want to do this. I'm willing to give this a try. It's part of a process of making the whole process very transparent. Here's what I'm going to do as a therapist. Here's what I need you to do. I need you to call me if I'm not call me on my faults if I'm not doing what I'm supposed to be doing. I'm going to call you if you're not doing what you're supposed to be doing. And so it's a very carefully orchestrated partnership, if you will, about what the therapeutic process is going to be, which I think is something that adolescents particularly need because they don't really know what the whole thing is about. But most importantly, even if you don't go a whole DBT way, these kind of emotion regulation, distress tolerance, interpersonal effectiveness, and mindfulness self-awareness are 4 skill areas, and Marcia has a separate skill manual, very useful in teaching kids how to get through those urges to harm themselves and how to get through challenging and difficult situations. They can certainly be integrated into a more traditional, if you will, CBT model. We use them all the time. These are just some of the, talk a little bit about one of the things that, because again, I think this is something that's important, that in Marcia's work, I hope you can see it in your handout better than you can on the screen, they really have kids go through a process of very carefully analyzing what were the factors that made them vulnerable to an episode of self-harm. So what were the vulnerabilities? Maybe they didn't have a good night's sleep. Maybe they didn't eat a good breakfast. Maybe there was a fight in their family. The vulnerabilities, and then the trigger, and then the responses, and then gradually working them through to develop what are alternative responses. When you find yourself vulnerable, we all have bad days. We all don't have good nights of sleep sometimes. We all get exposed to stressors, and what are alternative responses? And it's just a very concrete way to help a kid kind of move from, I just did it, I had to do it, I had this intense feeling, to really slowing down and analyzing every step of the way and beginning to feel empowered that they could take some action that would put them in control of the intense emotion that they're feeling. DBT has a lot of really useful concepts. This whole notion of wise mind, I feel like the adolescents really like this notion of wise mind, which is you really explain to them that a reasonable mind is that, I should do my math homework before I watch TV. The emotional mind is, screw that, I want to talk to my friends. And then the wise mind is kind of in between, where you make a compromise, you make a plan, you do some delay of gratification, you reward yourself, that's where your goal is, to try to get to that wise mind. It's a concept that the adolescents like. I'm going to move on here. The other thing, I just want to say something quick about MST, and that is It has some limited data to suggest that it's effective in reducing suicide risk with distressed adolescents. They've done it, the studies have been done predominantly with African American males, a very difficult population, I think, for many of us to get our hands on and to effectively work with. But it is a selective intervention in this context because it's very intensive. It's family and community based, so you work a lot with the family and the community. Intensive services for 3 to 5 months, which is great. High engagement, high completion rates, and it's been very effective with kids in the juvenile justice system. And the one study that's looked at it with depressed and suicidal adolescents, and this is not self-harming, but suicidal adolescents, found that the MST, there was a reduction in suicide attempts, but that both groups had decline in suicidal ideation, depression, and hopelessness. So it's still a intervention out there to think about when you're your families that have multiple problems. And then I think there's just one more. So here's some resources that you might want to copy. The first one is the Child Clinical Psychology website that has a lot of information about treatment resources and effective treatments and how you get more material on effective treatments or training or manuals if you want to check them out. DBT in Seattle can give you a lot of information, obviously, about that approach. And then this is the website for the American Academy of Child and Adolescent Psychiatry. And the one I'll close on, put another little plug in for, and it was in my redone slides, but they didn't get loaded on. And that is, I think, that any opportunity that you have to, if it isn't already kind of ingrained in you, are part of your style or your interaction, I would really encourage you to get schooled in the motivational interviewing approaches, because I think that interaction approach is probably the most effective approach in just working with adolescents. There have not yet been any research studies of it with suicidal or self-harming adolescents, so I'm not trying to go out on that limb. But I do think that the kind of open-ended questions, giving a lot of reflection, really saying, what do you think is going on, then doing some education, and then ending up with, so what do you think you're going to do? What does that mean for you? How does that seem to you? This kind of stepping back from a parental and didactic stance to a much more supportive and communicative, open communicative stance, we have found to be a really effective strategy to engage kids in the treatment process. And it is integrated now in most manuals that are talking about using cognitive behavioral therapy, and certainly in the DBT work. It's kind of this notion of making clearly that your work is a partnership with the youth and the family that you're working with, and that everything you do and say and how you act reflects that partnership, because that's really a way to get adolescents to feel empowered to take charge of their own lives and do better. So I'm going to stop at this point, and then we're going to convene, and a whole group of experts from your community, as well as myself, are going to be available to answer questions and hopefully engage with you in discussion.
Of nonprofits are complying with the living wage rate. It's voluntary for nonprofits. It shows that it can be done. And these are small nonprofits, small community-based local nonprofits that figured out what would work for them to be able to implement the increase. I'm really proud of them. I'm really proud of Santa Cruz for being visionary in terms of adopting this ordinance, and for the other kinds of visionary actions that the city has taken despite controversy in some situations. There have been a number of situations that have occurred, such as the passage of the ordinance prohibiting discrimination based upon appearance. Do you remember that one? And people thought, oh, this is really going to hurt businesses. Something else that was controversial at the time was the Greenbelt Ordinance. I mean, now people love it, are really happy, and we have, we've been on the forefront of taking positions on significant issues that then spread to other communities. So in terms of this position about being an island, what's wrong with being an island of a good thing? These are good things. Let's be the Central Coast Island of decent pay, and let's spread it.
Thank you. And now another chance for one more from each side on this. Go ahead,
I just
Casey.
want to say that I don't want to be an island of businesses that aren't willing or unable to pay benefits to their employees. Again, I think people aren't realizing that there's a trade-off that's going to be made, and you can say it's good for us to raise the wage, but if it comes at the expense of benefits, if people have to use all of the extra money that they make to pay for health insurance that they lost because their employer can no longer fund that health insurance, you're not really getting anywhere. So I also don't want to be an island economy, and I don't want to be a place that only looks at wages as the only thing beneficial to our employees and not looks at the entire picture of benefits, health care, dental care, paid time off, retirement packages that are needed for families in this community.
Okay. Anyone else? Okay, we'll go to the next one. The boardwalk and marinis and other beach area businesses have traditionally been the only employers of younger teenagers. These jobs are an important part of their education and work experience. Are young teenagers worth $9.25 an hour, and will they be priced out of these jobs? Who would like to comment on that?
Absolutely they will. There's not a doubt.
Right.
If you have
we'll have a
a-
panel who can do the talking on this. Well, we have a panel. We'll just have to stick with this. I'm sorry.
If you choose to hire someone, you go through a series of interviews, you have resumes, you have applications, you choose who you hire. So I assume that every business hires valid employees. If you value that employee, you pay them a livable wage. Bottom line. Bottom line. Of course, if a high schooler wants to work at Marini's and you hire them because you think that they're capable of a job, I'm sure you think that they're capable of living as well, and that they deserve to have money, and that they're valuable. So that's the bottom line. You pay someone. You pay them a livable wage. I don't want a slave shop. Done.
Charlie, go ahead.
Well, it's interesting that we're using the term livable wage for a high school student living at home. I would hazard a guess that a high school student can live on even less than the current minimum wage. They're just spending money for whatever snacks they want to obtain. No, there's a big assumption there. I can tell you from the high school students that I've hired, and we've hired a lot of them, and they've been great people, that they're just looking for an opportunity to get exposure to the work environment in any way, shape, or form. Could be loading soils, could be watering, could be sweeping the floor. I don't see where that entry-level position is going to remain in place if we're flooded with applicants from outside of the Santa Cruz area, from Scotts Valley, Capitola, Live Oak, who are going to take advantage of the higher wages that they'll be paid in Santa Cruz. Those positions simply won't be an opportunity for the high school kids in our community. And I can't speak for the boardwalk. I wish that Matt was able to address that issue. But I think you're going to see the same situation down there.
Okay, pass it that way, Charlie, for Arsene.
In response to that, you were speaking about high schoolers that are coming from middle to upper class families, and they're working just for the experience of working. But all the high schoolers that I have worked with are working to supplement their family's income because their parents are low-wage workers as well. I work with high school students that work 5 shifts a week while they are in high school. I mean, that's an unfair life experience, but they have to do it. So they definitely deserve to get paid as much as anybody else.
I think the problem we're talking about is those exact high school students will not be able to find jobs to be able to support their families, which kind of goes back to this issue that was brought up in the report that that if you raise certain income, you can also lose eligibility for public benefit programs. And I think that, like what Charlie was talking about, if you're in a business, we employ high school students as well, who are wonderful, and we love them, and we'd love to retain them. But if they're going to be making the minimum wage, then I have to tell people who have college degrees, that have graduate school degrees, that they will be making somewhat close to what somebody in high school makes. And that doesn't make sense from a business perspective. So either we need to raise all of our wages up the pay scale, as Charlie talked about, or we're not going to be able to employ high school students. And I think I said this earlier, but I just want to reemphasize it, that if you want to look at places like Santa Fe and San Francisco and what happened there, they saw an 8.3% increase in unemployment for high school students, and they also saw an increase in the dropout rate for high school students. And whether that's because they dropped out of high school to make more money by entering the labor force, or whether they dropped out of high school because when you take away jobs, they get involved in other activities, then that's another thing. But whatever it is, it just doesn't make sense from a business perspective to pay somebody, a high school student, $9.25 if your college graduates and graduate students and various other people are going to be making similar to that. It's going to be, those people are not going to be able to find jobs, and that's another potential negative benefit for people you're trying to help.
Great, thank you. Oh, one more?
I just want to add one more thing here. You know, I found it when I was preparing for this, I looked at some census information, and I found a statistic that I thought was really startling, which is that in the 2000 census, the median household income by age showed that householders under the age of 25 in Santa Cruz earn less than the rest of the state and less than the rest of the nation. Householders under the age of 25 earn less than the rest of the state and less than the rest of the nation. What this is, and this is in an area where there's such a high cost of living. I mean, we owe it to these young people. Many of them are families with children to be able to pay an income level that will be comparable to what other counties are paying, or definitely the rest of the nation. I mean, similarly, the income levels for, based upon race and ethnicity, Hispanic or Latino households half of what white households earn in terms of per capita income. So I'm looking forward to Santa Cruz making a change and paying a decent wage for these low-income individuals and people of color in particular.
It is 9 o'clock. We promised we'd be done at 9. So I want to, first of all, thank all of the panelists. They've been great, and we thank them so much. And I also want to thank all of you for coming tonight, and all of you watching at home later. We appreciate your watching. And lastly, I just want to point out, again, the Community Coalition for a Sustainable Economy sponsors this event. We have a yellow piece of paper around the room. If you're interested in our work and joining with us, please pick up one of those pieces of paper.
Don, would you mention our website?
You know, it's too long to say. It's too long a name, I'm sorry. But we do have a website, and you could visit Liz on your way out, and she'll write it down for you.
For the camera,
Pardon?
for the people watching television, is there a website they can go to?
It's, you see, it's hard, it's because it has symbols and it's sorry, but it just wouldn't work really. It's a temporary, it's not Googleable yet, so that won't even help. Anyway, again, I want to thank you so much for coming tonight and have a great evening.